Good morning and good afternoon, everyone. Welcome to the third seminar series of the OPHI Michaelmas Term Seminar Series. It's already week 3. And please let me remind you that this is an informal space to have some interesting and engaging discussions about multidimensional poverty specifically, but also human development in general. This is a very special workshop because we have some very interesting presentations. And today we have the pleasure of having Dr. Mónica Pinilla Roncancio and Dr. Paul Rodriguez Lesmes, both who are joining from Colombia. So before presenting our speakers today, let me remind you that this seminar is going to be recorded so that we can post it online on our social media platforms afterwards. And also, please let me remind you that we're going to have a lot of time for conversations and some questions afterwards, after the presentation. So feel free to just type in your comments or questions in the chat box that is available so that we can, as the presentation goes along, so that we can take them on at the end of the presentation. So today we're going to hear about Mónica and Paul about catastrophic payments and multidimensional poverty in 8 countries. So Mónica Pinilla Roncancio, she has a PhD in social policy from the University of Birmingham, and she's currently an assistant professor at Universidad de los Andes in Colombia, and she's also the director of outreach here at OPHI. And her main research interests are disability, multidimensional poverty, inequality, and generally health economics. Dr. Paul Rodriguez is currently an assistant professor at Universidad del Rosario, also in Colombia, and he has a PhD in economics from UCL. His expertise lies in macroeconomics with an emphasis in economics of health, using tools for program evaluation, natural experiments, and structural equation models. He has worked extensively for international organizations such as the World Bank, the Inter-American Development Bank, and the Institute for Fiscal Studies. So without further ado, again, let me remind you to please type in your questions as the presentation goes along. And yeah, so welcome and thank you again, Mónica and Paul. The mic is yours.
Thanks a lot, Ricardo, and thank you everyone for being here. It is a pleasure for me to be here with Paul in representation of our research group that includes people from Pontificia Universidad Javeriana, Universidad del Rosario, Universidad de los Andes. This is a project that joins the 3 universities, and we joined forces in order to analyze if there is a relationship between catastrophic expenditures and multidimensional poverty. Next, please. So we are going to briefly discuss different topics in order to introduce the topic of our main presentation that Paul will take charge of. First, I'm going to talk about the motivation and why we are here and why we are thinking about catastrophic healthcare expenditures and multidimensional poverty. Then I'm going to explain what are catastrophic expenditures and how those are related to poverty, and how multidimensional poverty can be a solution, or can be at least can give us a clue of how catastrophic healthcare expenditures affect multidimensional poverty. Then Paul will move to discuss in a little bit more in detail the objectives, the methods, and the countries that we include in our project, and the preliminary results. This is a work in progress. We have been working in this project for the last 8 months. So we are welcoming any feedback that you have about the results, any comments that you have. We are still working on the data and still finding a lot of surprises that we are happy to share here with you. Next, please. So, and next. Thank you. So when we are talking about the motivation, the first thing that came to our mind is the 2 SDGs that are related to multidimensional poverty and to healthcare. The first one is SDG number 1 that talks about ending poverty in all its forms everywhere, and especially target 1.2.2 that talks about reducing by half the number of men, women, children in all ages living in multidimensional poverty according to national standards. Also, we have SDG number 3, that talks about ensure healthy lives and promote well-being for all of the ages. And especially the target 3.8 talks about achieving universal healthcare coverage, including financial risk protection and access to quality essential healthcare. And in this point, it was really important to see what is the relationship between these 2 SDGs, and especially that part of financial risk protection, because financial risk protection talks a lot about a lot of things, but the important in here is that we want to prevent that people go to poverty or fell in poverty because they are paying for healthcare. Next one. So when we are talking about here, it's also, we are asking ourselves why financial risk protection becomes a target and how this is so important in the world of multidimensional poverty or just in the world of poverty. So we know that healthcare can be, or the shocks in healthcare can be one of the most expensive ones and are related to a health poverty trap. So we know that households who have a household head who gets sick, and because of that they need to pay for healthcare, and they also lose the employment of the household head, they are going to they have a higher risk of becoming poor. And this, it becomes a complex situation that not only includes the payment of healthcare, but includes losses in employment, children going out of school, selling assets, borrowing money, using savings. So it's a really, really complex situation. And usually what they are trying to do is that, or what is usually one of the main things or the main policies in order to reduce the financial risk that people can face because of healthcare is to increase the health insurance. But usually health insurance is not the factor that is always associated with not having out-of-pocket payments or a financial risk related to health. So what we see in the literature is that even though in some countries that have really good healthcare systems, still people face financial risk because of healthcare. So still people need to pay out of pocket, or they still people need to pay from their own income in order to cover the extra healthcare that they need. And because of that, they need to reduce our consumption, or they need to use different tools in order to be able to cover or supply that healthcare expenditures. That is, it's a new thing in their budget. Next one. So there are different ways to understand healthcare expenditures or catastrophic expenditures. So out-of-pocket payments is any payment that a household or an individual does without a health insurance. So if you go to the pharmacy and you pay for a pill, and the pill you need to pay from your own money, that's an out-of-pocket payment. But catastrophic expenditures are not all out-of-pocket payments are catastrophic expenditures. So there are different definitions that are related with the amount of that out-of-pocket payments. And there are two that are really common, that are commonly used. The first one is that around 40% of the disposable income, if the household uses around 40% of the disposable income, that will be a catastrophic payment. And the second one is that if the household expenditures on health are higher than 10% of the total household income. These two measures, it's supposed that are highly correlated, but the results are or depend on the different strategies that individuals will have. So there is information that says that, for example, individuals that if you use the 40%, you will see that households that borrow money, they're not going to reduce their consumption. So they are going to continue consuming the same amount as before, but because they are borrowing money, you're not going to see this. So this is a question mark, and this is really important for our research, because at the end, what we are saying is, okay, maybe how you are analyzing what is catastrophic payments is not completely accurate, or it doesn't allow you to see the impact that catastrophic healthcare payments or healthcare payments can have in the household behavior. And based on that, we start analyzing how different or what is the research around catastrophic healthcare payments and the different strategies that households include or they take. Next one. So there are a couple of things that are missing in the literature and where we are aiming to contribute. The first one is that most studies only use cross-sectional data. So when you are using only cross-sectional data, you just only know that the household face catastrophic healthcare expenditures because they spend a lot of their national or their monthly income or annual income in healthcare. But also you will see their levels of poverty. So you will not know if the person, if the out-of-pocket payments create or have an effect on the levels of poverty or were associated with the increase of poverty, Or you are also not going to see what are the changes in the borrowing money that they ask, or if they use their savings, or they sell their assets, or they took children out of the school, or a person who was not in the employment, they went back to the employment. So that's one of the main, or one of the things that we aim to contribute. And another thing is that because of the complexity of the household economy, let's say like that, it is really difficult to see what really households do in order to respond to a shock, a healthcare shock. It's not that something happened and the household just decide to stop eating or stop consuming, stop their consumption in something. It's that the households have different tools in order that they can face that shock and mitigate it and move on. So that's what we wanted to analyze. And we think that in this point, multidimensional poverty can contribute a lot. Yeah?
Yes, we can hear you again, Monica. Thank you.
Okay, Paul, can you move to the next one? With the connection, I don't know if it's someone in there or it's me, the one who fell the connection. Next one, please. So with this in mind, we think that maybe we also need to analyze poverty from a different perspective. We also need to analyze that poverty is not only income or consumption, but we need to analyze that poverty is a multidimensional aspect. And in that case, having a multidimensional poverty measure like the proposal by Kyle Foster can help us to analyze all the different dimensions. And in this case, we will be able to analyze how households use different tools and use different strategies in order to avoid to reduce their consumption, but that can increase the multidimensional poverty in the long and short term. So in here, what we are saying is, next one. In here, what we are saying is that when you see multidimensional poverty in this perspective, you are going to be able to analyze dimensions like school attendance. So we know by the literature that households, one of the response of households is to take children out of the school. So you have a healthcare shock, let's say the household health gets sick, children are out of the school, and children go to the labor market. So with those two things, we were thinking of, our hypothesis is, if you create a multidimensional index that can capture those changes in school attendance and in child employment or child labor, and also in employment and also in access to healthcare and in other dimensions, it will be easier for us to understand what is the magnitude or what is the real importance of healthcare expenditures. So those are our main hypotheses that we want to test with this project. And these are the things like the motivation. So now I'm going to give the word to Paul, who is going to explain in detail what are the aims of our project and what are the preliminary results that we have until here.
Okay, thank you, Monica. Okay. So let's go a little bit on detail on how we're going to do this. Sorry, 1 second. Yes, I start with this one first. So which is the specific objective of our project is to establish the relationship between catastrophic health expenditures and multidimensional poverty in low and middle income countries. So this means that we have several steps behind it. The first step, or the first specific objective, is to determine the factors that influence the likelihood of a household going into multidimensional poverty and its association with catastrophic costs. So as Monica was saying, we observe in the data, and we will see later, that there is an important correlation between a household being in multidimensional poverty and as well on the situation of a catastrophic cost or catastrophic expenditure. But there might be several characteristics that link them together and not necessarily that one causes the other, right? So we will start by considering these characteristics. Second, we identify and classify the mechanisms behind on how a catastrophic expenditure might be related to multidimensional poverty. That is to understand the specific components of the multidimensional poverty, on why a catastrophic event might change one of them, right? So perhaps they are changing their level of assets, perhaps they need some additional income and then send their kids to work instead of going to school and so on. So these are the mechanisms behind on how these two variables are linked. Third, we will compare the level of catastrophic spending and mechanisms in general across 8 countries. So we'll basically work with Colombia, Uruguay, Chile, Mexico, Uganda, Malawi, and Tanzania. So far we are going to show you results on 3 of them that we have already processed. And finally, propose policy recommendations to reduce the levels of catastrophic spending and multidimensional poverty according to the characteristics of each country. So actually, for some of them, we were able to observe changes in the design of the health insurance systems of each country. So that can actually help us a little bit to do this type of analysis. So, which is the central methodology here? What are we going to do? Basically, this is a longitudinal study. So basically, we observe changes on catastrophic payments, how they are affecting multidimensional poverty, or the probability that household is classified as a multidimensionally poor. Here we're showing results of Uganda, Malawi, and Mexico. For some other countries, for instance, for Chile, we have already do like an analysis and find out that the data available is not that doesn't allow us to do the exercise. So initially we proposed 8. I guess we will end up with something like 6. In this moment, we're also working on processing the data for Colombia and Tanzania, and hopefully we will have like some extra countries processing in the next couple of months. So what I'm going to present you here is that for these 3 countries, we have analyzed health expenditures, catastrophic payments, and the link between them using a linear panel specification. So as Monica was saying, we are using this Alkari-Foster method to compute the MPI. So now we'll get back a little bit to this one. So on the dimensions, most of the analysis, we are using the international version of the Multidimensional Poverty Index. And this is for the reason of comparability. Each country has as well its own definitions. It has the different dimensions somehow, different weights. Here we're basically facing on these 6 items: school attendance, employment, asset ownership, financial inclusion, province savings, and child labor. For some countries, assets means a little bit a different list of items. Employment, for instance, in Mexico is not only employment, but it's also formality. And there are small differences between them. What we are doing here is trying to standardize them into a same metric, so we can actually say something that is relevant for all countries. But we will see in a few moments that this is not as simple as I'm saying. So this horrible table that I'm presenting here is now the complete list, for instance, for Mexico. So where we have health, education, employment, standard living, quality of housing, which are equally weighted. Then within them, we have different type of items. For instance, in health, we have access to health services and health insurance. Then, for instance, a country like Mexico, deprivation in health insurance is not a big thing. After 2010, more or less, because of the entrance of Seguro Popular. Before there, then we have a little bit more variation on this item. For Mexico, so we have information from the Encuesta de Condiciones de Vida de los Hogares. It's called. It's 2002, 25/6, and 29/12. So basically, we'll be observing 2 waves before Seguro Popular, 1 wave after Seguro Popular, which has a dramatic change on this indicator. As I was saying, Mexico, there is also like a small difference For instance, we have informal labor. Formal labor is considered for the Mexican case, but it's not considered, for instance, for the case of African countries that we have there. On the other dimensions, then, as we will see, for instance, now with Malawi, the dimensions are more or less the same. It's mostly on this component of labor that there are some differences. Right. For the case of Malawi, we're using the integrated household panel survey for Malawi. This is information for 2004-5, 2010-11, 2016-17. So the Malawi data is a little bit like more spaced over time. Again, the definitions and the weights are more or less the same. But I don't have here the ones for Uganda. For Uganda, we're using the Uganda National Panel Survey, 2005, 2010, 2011, 2013, and 2015. Some of the most complete ones that we're using. So, okay, so let me show you a little bit of the statistics of what we have and this correlation that I was mentioning before. So for the case of Mexico, so what we observe in this graph is the proportion of people which are classified as being multidimensional poor, according to this characteristic that we were looking. Essentially, from these characteristics, we obtain an index. Like for each characteristic, the C index, we weight them according to this percentage that were in the table, and according to a cutoff, in this case is 40% the index, then we decide that the household is classified as multidimensional poor. So in the light colors, you have the households which have a catastrophic payment, according to the definition that Monica was saying, that a household expends 40% of its total expenditure taking out food consumption on health items. This could be like any combination, whether it's services, co-payments, medication, and so on. And what you observe is that for this type of households, for instance, in 2002, 20% of the households were classified as multidimensional poor, and without catastrophic payments is 19%. This is on the first wave. And the following ones, 2006, 2012, we still see this gap between them. One quite interesting is 2012 because Seguro Popular is already there, but we still see that there is a difference. So one question that this type of information tells us is that if it's causal relationship between the catastrophic payments or the event that involved like move the household into a catastrophic payment scenario with multidimensional poverty. Okay, so we have two questions here. One is by Chica Payne that said, why we're choosing these 8 countries? Basically, we're choosing these 8 countries because it's the ones that we identified that there was longitudinal information that we can actually use for this study. So for some of them, for instance, this case of Chile and also of Uruguay, at the end, we didn't find the information that we want. So if you have any suggestion of other countries apart from these ones that we were mentioning, that we have a longitudinal data set for households that have both expenditure and the information needed to construct multidimensional poverty, we'll be happy to hear about it. But that's the reason. We choose these 8 countries because we're the ones where we identify information.
Well,
Okay,
sorry,
yeah.
may I just suggest maybe we can continue with your presentation if that's okay, and then in the end we will have some time
okay.
for questions, and if in that way you can continue more smoothly, if that's okay with you.
Okay.
Perfect. Thank you very much.
Okay. Okay, so these are the levels of multidimensional poverty and catastrophic payments in Mexico. So we will change the definitions over time. We will show you some results of the main results, changing the cutoffs for multidimensional poverty, and as well the cutoffs for classifying catastrophic payment, because the results will be sensible to this, as you will see. For the case of Uganda, then as well, we observe this positive correlation. Again, the light color is with catastrophic payments, The dark one is without catastrophic payments, and household with catastrophic payments seems to be in a higher level of multidimensional poverty. This is essentially what we will normally observe in the literature of catastrophic payments and poverty. We observed cross-sectional data showing that households that are paying more for their health are also poorer. What we want to do in this study is to find out a causal relationship using the panel. And for Malawi as well, this happens. 2016, there is a quite important hike for the case of households with catastrophic payments that we are still understanding why it's that happening. It's a particular high number. So now let's move into what the results are telling us. So this table basically comes from a linear panel regression. Essentially, we have households as the unit of analysis. We classify households as being in catastrophic payments in every point of time, and as well if they are multidimensionally poor. All of these regressions are controlled by socio-demographic characteristics of the household head. So there are variations because sometimes there is a change of the household head, the number of kids, people is dying, and so on. All these characteristics are taken into account, and we are following the same households over time. So this means that we have first to do an analysis to balance this panel data set. So at the end, this means that this sample is a bit selected. So these households that we are considering here for the three countries are households that appear in all three waves of these data sets. Normally, this means that these households are a little bit richer and more educated than the general population, which is the standard scenario with longitudinal data sets and the dropout over time. So each one of the numbers corresponds to a coefficient of a different regression. For instance, this 001 that you observe here is a regression where the dependent is to being multidimensionally poor in the period T, and the independent variables are to have a catastrophic payment, a 1-0 variable, and all the other controls. For this case, for catastrophic payments in T-1, what we are doing is an interaction. So we're interacting whether the household have a catastrophic payments in T-1 with the report of the household having a catastrophic payments in the period T. So then we have two coefficients for this regression, for the same regression. And essentially, we are not showing here standard errors because of the space, but as usual, the stars are our guidance if the result was significant. So what is the general take-up here? So first, for Mexico, with this level of multidimensional poverty, so we have that 19% of the households were classified as poor, right? This number is based on our definition of multidimensional poverty. So if you go and see the data that Mexico produced with their own definition of multidimensional poverty, you find that the number could be in 2016 of 43%, because the index have some other characteristics. For instance, it also has usage of internet and so on. If you use the pure IPM global, then the percentage is 6.56%, because there are elements such as this one of informality are not taken into account. So using this kind of harmonized version of the multidimensional poverty, the number is 19% here on average over the 3 years. For catastrophic payments, with this standard definition that a household expends more than 40% of their total house expenditures in health, taking out food, the percentage is 6%. So what we observe here, this 0.01 is when households change from one period into another to report a catastrophic payment, whether there is a change as well on whether the household is classified as multidimensional. So what we observe here for the three countries is that under these cutoffs, we do not find evidence that catastrophic payments actually are related either positive or negatively with multidimensional poverty. We observe it for certain specific characteristics. So for instance, for Mexico, what we are observing so far is that catastrophic payments basically keep people in poverty. It's kind of a poverty trap. So households that were poor in, for instance, 2006 are more likely to report to be poor in the next wave, 2012 in that case, right? If they report that they have a catastrophic payments. So essentially what is happening in this case, in the case of Mexico, is that there is a general trend, or there was at least until those years, there was a general trend of people getting out of poverty. But catastrophic payments keep people in poverty during this time. That's the general impact that we find for catastrophic payments. For the cases of Uganda and Malawi, we really don't find a clear effect. So here we have this huge number that there is an increase of 94 percentage points more on the probability of report to being poor. But with the caveat that with this 40% deferration of catastrophic payments in Malawi mean that only 2% of the households are doing catastrophic payments, right? So we're understanding this months why this number is that small. For this particular case of Malawi, there is a problem with how the service classifying health expenditures and so on. So this number, basically, we need to take it with a pinch of salt. What other elements allow us to do comparisons? So for instance, one particular shock that usually is important for households is an unemployment shock. This variable is whether the household have someone that reports to be unemployed from one wave to the other. And for the case of Malawi, it actually shows that it makes people more likely to be multidimensional poor in the following way, right? But at the end, it seems that it's not really that much about catastrophic payments, but it's more a little bit about the definitions of multidimensional poverty. So I will go a little bit later into that detail. So this is for this characteristic, multidimensional poverty with a definition of K40 and catastrophic payments for 40%. So we want to understand how sensible is this type of analysis to the definitions of these two central variables. So the first one will be to change the multidimensional poverty definition. So instead of going with this K40, we will move to K30. Essentially, what we're doing here is classifying more people as being poor. So now here, 34% of the people is poor in Mexico according to this definition, 81% in Uganda, and 63% in Malawi. With this change, we still have this idea of the poverty trap. In Mexico, now the unemployment shock, that is kind of our reference for the case of Mexico, is there, and it's a little bit more clear that a catastrophic payments can be related to having an employment shock in a household. For the other countries, we really don't see much difference. For Malawi, now we don't have that huge result, a bit crazy result that we have there. Now we have a negative one, but still for Malawi, our problem is the definition of catastrophic payments. So now let's change a little bit the other definition. Let me get back into the original regression. Now we will change the definition of catastrophic payments. So instead of being 40%, we move it into 30%. And now the story change. So for Malawi, we get a result that is a little bit worse than the previous one, but it doesn't change too much the proportion of people who is under a catastrophic payment in Malawi, 2.9%. But for instance, for Mexico and for Uganda, there is a big increase in these proportions. Now I'm getting back into the multidimensional poverty of 40. And in this case, we don't observe that, or at least it's not significant, this result of the poverty trap. So for this reason, we're still a little bit cautious on essentially the interpretation of the results, because they seem to be sensible to the definitions of both multidimensional poverty and catastrophic payments, which make it a little bit more complex to draw conclusions. So I was going to show you these ones. I have still some time. So these will be the impacts over the specific items. So for instance, this is for the case of Malawi. We have here the different cutoffs for the definition of catastrophic expenditure. And what we observe in general is that there are certain deprivations that react in some dimensions and others in the other direction that we were expecting. So for instance, this is the water deprivation and like access to safe water, and with certain cutoffs of the variable, what we observe is that it's increasing deprivation of water, which is something that we still need to understand because most of these variables are constructed based on the distance to water sources, to clean water sources. So why it is changing with catastrophic payments, we still have some doubts. With health access, essentially there is a reduction in deprivation. So these make us think a little bit on whether this type of indicator, for instance, health access, is actually a good idea for this type of analysis, because actually it depends directly into whether there is someone sick. So if there is someone sick, perhaps I do something or access certain program that allow me to get access to health services more swiftly, right? So then there is one interesting question for the discussion. And so on. There are others interesting here as a school attendance as well. Assets, which was basically one of the central elements that we were considering at the start. Our hypothesis based on what the literature says is that essentially if there happens certain event that send households into catastrophic payments of health, people will have to sell certain assets in order to cover their health expenditures, and then this will increase the deprivation in assets. Actually, we find that this, for the case of Malawi, it only happens with very high levels of catastrophic expenditures. For the case of Uganda, you can see it's more or less the same idea. Then it's negative, so there is a reduction in the deprivation of health services. And for the other variables, there is really not a change. I'm showing you one version with the definition, with the standard definition of multidimensional poverty, but actually this doesn't change too much. And for the case of Mexico, the main result for Mexico is actually coming not from assets, household, but actually for school attendance. So what this poverty trap that I was indicating a little bit before basically is coming from household needing to send their children to work rather than keeping them into the school, or not to work, or at least they can be caregivers. This is another possibility. So I have just show you a little bit the small details behind this, but I guess given the question that I'm seeing here, it will be interesting to have a discussion around these items. So we get back a little bit to this. So okay, so this is basically what we wanted to share with you. We're not putting here some conclusions, basically, because I was showing you a little bit before. We're still having troubles trying to understand exactly what it means, these results. If we can actually say, for instance, that there is this poverty trap effect in the case of Mexico, or if this depends a lot on the definition of what is multidimensional poverty, which is one of the central elements. So for the case of the two African countries that we're analyzing here, we might be considering that actually these particular dimensions are not changing too much. They are not reacting too much to catastrophic payments. And as one of the questions is highlighting, perhaps there is a problem on how to classify catastrophic payments. So for instance, if we have a catastrophic payment, and this is affecting poverty. The problem is that perhaps I'm only able to do a catastrophic payment if I'm not poor, right? Or otherwise I have to accept the shock and not pay for the bill with the consequences that it has. So that's the reason we were also showing into these results. Sorry, the disease shock, but the disease shock is not showing as well, like a clear response that we can map for every country in the same dimension. So, okay, so we're open now to questions. Thank you very much. So Paul Rodriguez with Monica and our teams from several universities here present, research assistants and undergraduate. Thank you.
Thank you very much, Paul and Monica. Now I think we have a lot of time and a lot of interesting questions already to set some discussions going forward. So perhaps one way to start the discussion is the following question by Juliana Milovic. How do you select the indicators that are going to go into the MPI, basically? Because I think that defines the results that you get.
Yes. If you want, I can go. Oh. Okay, so it was a long discussion, and mainly we tried to include indicators related to the aspects that we knew that households changed. So we include indicators related to school attendance. We try to include indicators related to borrowing money or savings, and also employment and asset index. So the definition of these indicators was based, like at the beginning, we start like with a wish list of indicators that we wanted to include, and that those indicators we knew that according to the literature will increase, the deprivation of those indicators will increase because are the usual things that change, that households change when they face a catastrophic healthcare expenditures or when they face a health shock. So we start with that. Then we went to the data and we figured out that there were not so many indicators, like information on borrowing or information on savings account in Africa is really, really bad quality, or we don't have that information. We have it for one way, but not for the other one. So then we start like including the indicators that we really wanted to analyze, and we were related, we knew that were related to poverty and were related to catastrophic healthcare expenditures, and that were available in the countries in the 3 waves and good quality in the 3 waves. So because of that, we have like an MPI for Mexico and Latin American countries that is like more middle income MPI, has different indicators, and another MPI that is more for Africa that has other indicators. We have data, for example, in savings in Malawi, but no one has savings. So if that was another thing that we did. So at the end, we try to have a lot of imagination. In some of the discussions that we were having with the team, we wanted to include information related with expenditures on food and see if you include that indicator, how it moves, but that also has considerations. So we were like sticking to the common indicators, but also to the indicators that we knew that were going to supposedly, according to the literature, to move over time. So those were like the selection. And the selection of the deprivation cutoffs, I don't know, Ricardo, should I go ahead?
Yes, please. Yes.
Yeah. So the selection of the deprivation cutoffs is the same. We first base it on the global MPI or international definitions. We check like in the case of Mexico, or in the case of Uganda, we check like the national definitions that they have been using. We check that. We defined those the indicators based in global and national MPIs. And for the poverty cutoff, we conduct a robustness test in the distribution to check if we take like 40% for everyone in Uganda, no, in Mexico, no one will be poor. And if we take 26% in Uganda and Malawi, everyone will be poor. So we start like defining the different, taking the different normative decisions according to the context of the country, trying to keep the comparison between countries. But the most important for us is to have the comparison across time for each of the country in order to know. Yeah.
Thank you very much, Moni. So I think that's very important because that allows us to have a more informed discussion about the results. So for example, I think a lot of people are asking about the results about the assets indicator. So basically, how do you interpret the significance in assets, the result that you get in assets? And that is also tied with Sadia's remark about the fact that the intensity of the catastrophic payment is connecting to the selling of assets, and whether that result that was found for one country actually can hold for other countries, and why.
Okay, so
Paul, can you
yeah.
go to the asset, please?
Exactly.
Okay, in this one, so the assets increases. So yeah, as Paul was saying, like we are still trying to understand this, because in here, these are the sensory headcount ratio. So the person is multidimensionally poor, and it's going to be deprived in here. So in here, what we are saying is that once the person, if they are poor, like the sensory headcount ratio will increase, so they are going to sell their assets. But this is not a finding that we are going to have, or that we have for every country. So that's one of the things that we are like a little bit trying to understand. And the point in here is that households, depending on the shock, of the magnitude of the shock, they are going to use different tools in order to reduce the magnitude. So if they have a shock that is like, I don't know, 100 pounds, it's the household income is 200 pounds, for sure they're going to do a lot of things. But if the household have like 500 pounds and it's 100 pounds, that will be another difference. What I mean is like the definition of the catastrophic healthcare payments will affect a lot what households do. And also it will affect a lot what are the characteristics around the household. So what we are seeing in here in Malawi, and we need to explore more in detail this data, is like households are selling their assets. But we don't know if this is like a common thing that they do, or is the first thing that they face. So they have a catastrophic payment, and the first thing that they say is like, okay, I'm multidimensional poor, I'm selling my assets. Or if at the same time they are doing another stuff. So for example, we were expecting all the time, like our main hypothesis was like assets deprivation will increase, child labor will increase, and school attendance will increase. And what we have seen is that in some countries, school attendance increase, the deprivation. So maybe in that context, households are taking their children to school. And in another countries, assets increase. And in other countries, neither of those increase, but increase the deprivation or access to healthcare. So people is like saying, okay, children continue going to school, I'm not going to sell my assets. What I'm going to do is not go to the doctor. And these are things that we are trying to analyze. And I guess in here, what is more complex for us is that this is the joint distribution. So people can do different things and can increase their poverty in different ways. And it's not straightforward to say you move from A to B. So we wish we will be able to say this is something that we will expect in all the countries. But what we are seeing is that countries, depending on the magnitude and depending on the context and depending on everything, have different reactions. I don't know, Paul.
I guess that's a good summary. It's like we really were expecting a clear result in terms of the assets, like assets and, for instance, school attendance. But Malawi is a good case that showing that the result is not that obvious. So, for instance, we are observing more assets, like more deprivation on assets on very high levels of catastrophic expenditures. These two numbers would reflect something like 1% of the population. That's a caveat to take into account. But as well, we observe a decrease in the deprivation on child labor and school attendance. So we're still dubious a little bit on how to interpret this directly.
Thank you very much. So there's a lot to be discussed on the assets thing. And I guess that as you move along with the project, more results are going to come to help interpret that relationship that you're finding preliminarily. And now moving on to the actual use of the catastrophic payments variable. So Nikolai Supa asks, why do you focus on catastrophic payments rather than the underlying health shocks themselves? So maybe yes, some catastrophic payments are the result of more stable problems in the household, and others can be the consequence of a very volatile expenditure because of an accident or something. So, do you have any comments on that?
Yes, like this is actually a point that we have been discussing a lot and I also saw some question about the causality and possible reverse causality on this dimension. And the problem is that is to identify the health shock. So which was our ideal plan here? Is like we have a health shock that we can observe. This is kind of an instrument for a catastrophic health payment. And then as a result, we observe the change in multidimensional poverty. The problem has been on measuring properly these health shocks. So in some countries, the only information available is that if someone was sick, whatever it means for the respondent in the last 2 or 3 years, which could be a cold or could be a terminal cancer. There is no actually a way to be clear about it in some of the surveys. And for this reason, what we're showing you today is only the relationship between the catastrophic payment and multidimensional poverty. Our ideal, the ideal scenario is this one, is to try to get a clearer variation. What is the best that we can do in some of the countries? What we have is the list of chronic conditions. So we observe if there is a change on whether the households report that someone has chronic condition, diabetes, high blood pressure, and so on. And that might actually help us a little bit to try to use the data in this direction. But we share the comment of Nicola. There is a problem with that. And we need to understand better how we can handle this data, which perhaps will mean that at the end we will need to select from the countries that we analyze only a group of countries for which we can actually construct the variables of interest.
Thank you very much, Paul. So again, with Nikolai, he says basically how poor can the poor get. So he says concretely, there is a logic to expecting that poor people in T-1 will actually be more affected by the shocks. However, how poor, they are already deprived in a considerable amount of indicators. So how many indicators can they actually I mean, how many more deprivations can they actually acquire?
Yeah, this is one of the central points, and that's why we're showing you results, or one of our interests is to show results in general with different definitions of multidimensional poverty. So for some countries, as we were observing, we'll just go back to one of these tables. So for instance, with this K30, the percentage of poverty in Uganda is already 80%. So it means that the actual 1-0 definition of poverty, it's very important. If you have already these high levels of poverty, it seems that these catastrophic payments are just something else where you don't have really degrees of freedom to adjust anything. Right, as Monica was saying, in Malawi, there was no win with savings. So this is a dimension that you cannot actually affect. So that's why we're analyzing this on this version. We are also analyzing another version we're not showing you there, but it's with the indexes directly, like the continuous variable, where we will kind of capture like how worse can the situation be, at least on this continuous sense. The results are not too much different to what we're already showing you here, at least at the moment.
Yeah, one thing that just to add to what Paul is saying, it's like we have explored different definitions. So like, as Paul said, we use not the poor, no poor, but also the sensory head count, the C vector, in order to see the continuity. We have seen different indicators. And one of our assumptions in the case of, for example, of Uganda, is that maybe what happens in households is that they are having facing this trade-off, facing this increase in deprivation, but maybe it's not that all children went to school and now one child is not going to school. So maybe before it was like 2 of 3 children went to school and now it's 1 of 2 or 3 children. That is also really support in the literature. So because the index doesn't allow us to see the deep, the severity or the intensity, the severity of the same deprivation, that in that case we're losing. when we saw this these results in Uganda, we have been discussing, and one of their assumptions is that yes, maybe it's that in there they cannot become poorer, or maybe it's that as I was saying, like one child was attending to school, now no one is attending to school, and that the deprivation didn't change. So that's one of the things that that we are trying to explore. And as I was mentioned, it's because in here it's not so direct, and households are acting or reacting in different ways. So the deprivations, if we see, for example, we analyze each of the deprivations by each of the K value one by one, and we see like a lot of jumps, like people get the private, not the private, get private, not the private. And so there is not like a result that we are saying like, yes, this is what is happening, but it's more like a combination of the strategies, what it looks like people do.
Okay, thank you very much, Moni. So now perhaps it would be interesting to discuss whether there is an interest to separate direct and indirect effects, because as Nikolai pointed out, you could be capturing direct health effects because of the catastrophic payments, which are associated to the catastrophic payments themselves. So basically, the catastrophic payments could be capturing two kinds of effects: directly health related and also monetary related, spilling over to other indicators. So do you think it would be worth separating those effects?
Yeah, that's definitely the ideal. So which will be ideal experiment, also like looking at Juliana's like a suggestion. Ideally here you should have two types of scenarios. One where you have a health shock, but the health shock have an impact by health on the probability to being poor because you cannot work and so on, like the health effect of the shock. But you are insured. So if you have a health insurance, then you don't have catastrophic payments, and that's it. In the other scenario, you don't have catastrophic, you have the same type of shock, but you don't have the health insurance. So then on top of the direct effect of health, you have the second effect, that is the financial effect. So with that type of situations, you will be able to disentangle both. So that's part of the second part of this project, and is to try to find out in each particular country how we can like take advantage of these scenarios. So for instance, for case of Mexico, we have the case of Seguro Popular, and perhaps we can use that policy change that it's in the middle of the data set to try to do this disentangle part. That's the idea at the end of the project. Let's see if we can find that for each country. Like that's not that obvious in the scenario.
Okay, thank you very much. And perhaps one related question, and maybe it can be the last one given the time constraint. How do you control for income effects or for income shocks that have occurred, for example, while you're looking at the households over time?
We haven't, if I don't remember well, we haven't included income shocks or income effects. Please correct me, Paul, if I'm wrong. Like we have been working with expenditure data. We try to do it with income data, and we try to analyze like both, create catastrophic payments in both, but we only stay with expenditure data because income data is really bad quality. So it hasn't been able, we haven't been able to include it in any of the controls or in any of the analysis, because in most of the countries, 50–60% of the population doesn't have information on that, and the ones who have information don't have good quality data. So we haven't included this type of controls or control for income shocks around the time.
Yeah, so what we have here are some quantiles of the total expenditure distribution, basically. That's the closest to that we have for this.
Okay, so thank you very much. There's certainly a lot to be discussed, and sadly we have little time, but perhaps going forward, since this is an ongoing project, maybe you could try to consider some kind of natural experiment. So for example, whether there were some kind of pandemic events, or depending on whether data permits, actually you can use the current pandemic as kind of a before and after difference in difference scenario for some countries if data allows. And yeah, going forward, I think there's a lot of interesting results to still uncover, but these are certainly very, very interesting preliminary results. So thank you very much to Monica and Paul for this interesting presentation and for actually igniting a lot of debate and discussion, which is always fruitful. So again, thank you very much, everybody, for attending. And we wait for you next time, next week at the same time on Friday, to hear about Richard Freund's proposal of a child comparable measure internationally. So again, thank you very much, everybody. That's all the time we have for now. Thanks you again to Monica and Paul. Everybody have a good day and a good evening. Thank you.
Thanks for the invitation.
Very much, Ricardo.
Thank you.
Thank you for all your questions that really helped us at this stage of the project.
Thank you. Goodbye, everybody.